So good morning, everybody, and thank you so much for being here for my talk. I am going to present today the research we've done so far in Dr. Manio's lab at ETH on essentially using AI embedded in wearables to give a safe, continuous way of predicting sepsis in predominantly the pediatric and neonatal population. The way I structured this talk was a little on the high level because I didn't want to go into too many technical details, but give you an overview on the sort of clinical support structure that state-of-the-art AI embedded in wearables can provide in the clinical workflows today. So to begin with, my application focus is on sepsis. Now, why sepsis? Sepsis overall, across all populations, be it pediatric or adult, has a really high healthcare burden. The incidence per year is about 49-50 million. It causes 19.7%, 11 million deaths per year, and of course, the associated direct and indirect costs are astronomical. In the pediatric and neonatal healthcare, also you have about 1.2 million children who have it and about 3 million neonates who get sepsis every year, with a mortality that ranges depending on the severity of sepsis, be it severe sepsis or septic shock, from about 11 to 19%. So there's a huge problem here which is not solvable even in the most advanced nations with the best healthcare systems that you have. So the question was, why is this? In the previous talk by Dr. Anna, we saw what happens with the heterogeneous representation of a disease. And sepsis itself is sort of organ dysfunction that is caused by a dysregulated host response. I won't go into a lot of details, but essentially to tell you where this heterogeneity comes from, when there is any sort of infection in our body, we have different immune systems that start coming up in action and that try to subdue this. So there are anti-inflammatory and inflammatory responses from the body, and they each go to try and combat this infection. This is a delicate balance, and there's no saying how a particular individual with a particular phenotype, genotype, might actually respond to this. And there's this very small valley where if you don't respond properly and if the patient goes into something called immunoparalysis, where the immune system no longer knows how to react, whether to attack the body, to attack the infection and so on, the patient can start going into a deterioration valley. And essentially, this is where the problem happens. So clinical treatment right now, like the one that can ensure a really high recovery rate and low mortality, is catching the onset of sepsis early on and administering what they call right now the hour one bundle, which is essentially broad spectrum antibiotics, fluid resuscitation therapies, of course, vasopressors, blood cultures to really, really indicate whether or not this patient has sepsis. But first, we need to be in some kind of know-how that is it even possible. And for this right now, I know very recently there has been a new definition of sepsis because this also keeps changing and clinicians have a lot of debate about how to really term and identify this early on. But so far, what has been used since about 2016 is the SOFA definition. And the SOFA is a sequential organ failure assessment score, which is a medical score, and it depends upon analyzing the different organ systems in the body, which includes, let's say, the liver, your respiration, your blood gas levels, your blood pressure levels, how are your kidneys functioning, so your creatinine levels, and also your mental status. And taking this, they formed a medical score, and they basically take this categorical sequential score, which a staff member would have to then calculate and then assess whether or not the patient actually is in the threat of developing sepsis or not. Going a little bit further into this, and I need to lay the background of then where I come in with our research here. There are three kinds of data that are collected. One is physical observation by the clinician or the clinical worker or the nurse. There is vital sign monitoring, especially in the ICU. This is done quite frequently to see if a patient who might develop sepsis after severe infection, organ failure, or post-operative care might have. And then, of course, there are the laboratory-based tests to say, figure out what are the creatinine levels, what are bilirubin levels, what are blood gas levels, whether or not there is any kind of gram infection, and so on. And what finally is done is that they look on the timeline of the patient, and something called the suspected infection window is analyzed. And this is basically when the doctor feels that maybe blood fluids samples should be taken to analyze these chemical biomarkers, or antibiotics should be given. And they look when the SOFA score changes by 2. And that's when clinically it is said that this is the onset of sepsis, if they can identify this in a timely fashion. What that looks like is something like this. So you have multiple different parameters: temperature, respiratory rate, white blood cell count, shock index, systolic BP, heart rate. And you take all of these and you say, based on this method of calculating it, we have sepsis here. Now, as engineers and people working in AI and informatics, our job is to sort of raise the alarm before this can happen. Raise the alarm when a patient is sort of down spiraling in that trajectory where organ failure is a possibility. However, there are certain limitations with the sort of data that we get right now, which is a direct consequence of the current clinical practice. Now, most of the vital sign monitoring, most of the lab results, they are ordered in the ICU or acute care, essentially. So all the care is sort of, it's structured in one particular section of the hospital. So patients who are, let's say, immunosuppressed because of cancer, HIV, or so on, they are monitored, but not as frequently as ICU patients are monitored. So the bulk of the data is in the ICU, but what about all the other patients who are in different settings? And I'll talk about this a little bit more later. Secondly, a lot of the procedures are invasive. So be it arterial catheterization for blood pressure, be it urinary catheterization for knowing the urine volume or the urine production of a patient. These are all invasive procedures which come with their own inherent risks of infection. And then again, the density of nurses, clinicians in the ICU is way more than anywhere else. So this is also the level of care that changes from center to center, primary, tertiary, country to country, and so on. So it's not very homogeneous, and it's not very, it's not similar across the spectrum of places that we see. And finally, one other thing is that these are mostly intermittent measures. You don't go and keep pricking the patient like this little baby there to get a blood sample from this child every 2-3 hours. And you don't know how fast this child's phenotype is changing in that time, going to a certain organ failure. And blood cultures take about 24 to 48 hours to really get the results. So things are quite time intensive, and there are delays in recording these medical records. And of course, as shown in this picture, this is highly uncomfortable for the patient, for the parent who wants to go and hug their child. So there are many things here. This web of wires has its own cascade of infections and tears and all sorts of injury. So when I started looking at then the broader spectrum in the hospital, there was the inpatient setting and there was the outpatient setting. In the inpatient setting, as I mentioned, acute care is generally well taken care of in most hospitals. But even there are still the issue of the multi-wire web that a child is encapsulated in. There are still invasive procedures that have to be taken to get correct analysis. And then, of course, lab dependence, as I said, are time dependent, and this is a time critical analysis and treatment that you have to give to the child. Secondly, even if you go outside in the general care, so you go into general wards, the patient to nurse ratios are skewed. The nurse probably comes to you every 3-4 hours and not very continuously looking at you. The vital measurements are sparse, so you have sporadic checks, spot checks, which are taken, then put into the EMR, and then, so there's a lot of delay that follows in the whole clinical workflow. In the outpatient settings, the patient is self-reliant. So if your child is sick and you take the child home, you as the parent have to see what is happening with the child, right? There is no accurate measure, maybe a little bit of temperature and so on to really see if your child is fine or not. How do you know how fast you should respond to go to the hospital or not? So these were some challenges that we looked at, and we wondered, what could we do where technology could actually circumvent these particular limitations, namely to be ubiquitous, so you could be in every kind of setting, to provide something that was comfortable, that didn't involve these Weber wires and could make care easier, and finally to give some kind of indication, some kind of risk score of how are the main organ systems of this patient, how are they responding to treatment? How are they responding in time? Are we getting better or are we getting worse? So with this was born the Paediatric solution. And essentially, we have a system of binaural wearables, which can take essentially all the major vital signs, which are representative of how, on a high level, your organ systems are functioning. And then further ahead, we went and said that we would take each of these. We wanted to study the interplay of these different vital signs with each other. So how does, let's say, the cardiovascular system get affected by your kidney shutting down or your bilirubin not being in the correct range? And then finally, with that, giving some kind of medical decision support to the caretaker, to the nurse, to the clinician, to know, A, how is the patient doing? How is your child doing? B, to let them know, are they responding to treatment or not? To also sort of give the clinician an insight into if the kidneys are not functioning, if the urine output isn't enough, should I order a creatinine test? Should I order another test? How should I go about it? How should I diagnose this patient? So this is the sort of analysis we had, and we decided to start with sepsis because it was the most complex problem of all that we saw, in which different organ systems were involved and different organ systems could go down into failure. So finally, we came up with these wearables, which I'll be showing you in a minute, which could take the major vitals that are of interest, but could go beyond. So for example, with these simple patches in the Paediatric solution, we could take respiratory rate, heart rate, the normal ones, but we could also look at the inhale-exhale times, inhale-exhale sounds. We could look at the blood oxygenation, the tissue oxygenation. We could look at the variability in the heart rate. We could look at the blood pressure, both systolic and diastolic. We could look at pulse arrival times in a person. The temperature, of course. We also looked at body movement as a state of activity, inactivity, shiver, seizure. So we could differentiate between these to know what's happening. And then we used also these to be sort of neurological markers, because that is one place, I think the brain was one place that could not be encapsulated in this. And finally, which hasn't been done so far, and which is kind of the novel biomarker that we bring in this entire system, is urine output, non-invasive urine output. We have run studies where we could calculate this urine output from the lower abdomen region, where the bladder is off a person, to actually say what is the urine level in there. So you could get a granular 5-minute analysis on how well the kidneys are filtering, given the amount of fluid you're giving the child or the person. So all these digital biomarkers, I would like to talk about the sensors that we're using, because it's because of these sensors that we're kind of getting to this point. So we actually started using very novel sensors, some which just used the electrical difference in the body. It started looking at essentially charge differences in the body to kind of give us assessments. So for example, this is really used a lot in our urine model, where we put, as you can see over here, we put 4 electrodes on the lower body, and we basically we calculate the bioimpedance, which is the impedance of the biological tissue in a localized way. And we saw that we got very, very good correlation between how the census data was changing and how the bladder volume was monitored. We then modeled this. We have an algorithm which predicts this, and I'll show you the results in a little bit. Similarly, we used many different sensors. We used optical sensors. We used movement sensors that kind of characterized how well the blood is actually flowing within the arterial system. This is also a method of knowing the density of blood sound, so we can see the morphology of this change and get many different features extracted from here. And finally, what would be shown to the parent or the clinician or the nurse is something like this, where it'd be like, okay, heart rate's this much, SpO2 is this much, respiratory is this much, temperature is this much, activity is this, bladder volume is this much, and so on. And of course, there are many other features also that one could extract if the need be. So these are our 2 wearables. One is a cardiac patch. I'd say that this is about 10 centimeters at the moment, and we're in the process of making it even smaller, especially given the application on children and neonates. So we probably have it at the end to be about 5 to 6 centimeters, so that would be this much. It would go over the chest, essentially. And this is the urine volume monitor, which also, as you can see, is similar, which has different applications than this one. And what we found was, finally, that the cardiac patch, it actually gave really good performance for the different parameters that we were looking at. This, I must also put a little caveat here. These are results that came in adults, not in children as yet, because Swiss ethics deems that we get to adults before we get to children. So that's the next process that we're onto. We're pushing onto that. And also for our bladder monitor, we get very good accuracy right now. Our end volumes the errors are about in 30 ml, which is, as I've been told by urologists, for adults, this is agreeable. But for children, we're trying to get even lower because their volumes are smaller to begin with. And this is ongoing research right now at Kinderspital that we're doing. Finally, now I'd come to the prediction side of things. So now we have all these different digital biomarkers, and we want to go into the point where we start looking at sepsis per se. I don't want you to get too confounded by this table. I just want you to focus on the red box therein. So these are basically different open source data sets, and sepsis has been tried by many different groups in the past to predict it in the future using different open source data sets. And as you'd see, they use many different features. What does that mean? That means that they use the entire electrical medical records. They use the available vital signs. They use the available chemical biomarkers. They use the available demographics that you have. And with that, they're trying to predict what is the risk of a patient developing sepsis. That's one point. And as I mentioned before, lab values are sparse. They take time to come. So for our research, I didn't want to emphasize those. I wanted to stick with the biomarkers that we could generate with our binaural wearable system. And the other thing that I'd like to highlight is this column here. Retrospective analysis vis-a-vis online real-time analysis. Most studies that have been done so far always look at the patient data as a whole, where you know when the adverse event of sepsis occurs. And looking at this, what prior art has shown us is that there is a certain pattern that you can actually detect and you can actually use to predict whether a person would get sepsis or not. So in layman's terms, this is an apples and oranges problem. Has sepsis? No sepsis. That's retrospective analysis. vis-a-vis online real-time analysis that has, people are working with this. This is time series modeling in machine learning terms. But this is harder. It's harder to train because everybody's data that you're getting, everybody's sick. You're not differentiating between a not sick and a sick person. You're differentiating between a sick person and a patient who got sicker. So this is a hard problem to solve. And this is what we try to do in our research as well, is saying that we reduce the features that we're using from large laboratory-based or clinical-based markers to just digital biomarkers, so that we could go in both inpatient settings and outpatient settings to predict whether a person would get sepsis or not. And moving from this, the first thing that I asked, also with the students that I was working with, was, is it even feasible? So if I use 7 vital signs from the electrical medical records, is it even feasible to look at sepsis? So what you're seeing here is at the time of inference. The blue here is a patient who never developed sepsis. And the positive patient, the orange patient here, the line here, is a patient who does develop sepsis. So we showed that indeed, given about, so these are samples and they're at a resolution of 5 minutes over here. So this distance that you're seeing here is about an hour. So about an hour before true onset happens, we could detect whether or not a patient could get sepsis or not. So this was like a qualitative analysis for us, that is it even feasible to do this? Does it even make sense? So yes, we saw that yes, there is something here that does make sense that we should look at. Now the whole question was, can we make this 1 hour, 4 hours, 3 hours, 2 hours, 6 hours? How long could we prolong this? So for this then, and I promise you these are the only super technical slides, I'll try to be as, give you as big an overview as possible. We devised a network where we put in about all the vitals that we could leverage. And at the end of this network, we just basically give a 1 or a 0, a 1 for a patient who will get sepsis in the next 4 hours, 2 hours, 3 hours, or a 0 for a patient who would not get sepsis, all right? And as I said before, if you look at the retrospective analysis, where we gave the entire time series of whatever 20 hours of this patient to the model, we got very, very high sensitivity and specificity for every hour of prediction. So 1 hour before, of course, we had the best results, and then as we went to about 4, so that there's a bit of a reaction time for the clinician or the nurse or the parent to take this hour 1 bundle steps that I showed right at the beginning. Now comes the more challenging part. So this was our neural network of doing it online. So doing it online, we went into quite a few issues. So what we devised was sort of a consensus algorithm, which is essentially looking at the positive predictions, negative predictions, and aggregating them such that we could get a prediction of a high confidence. And with this, what we saw was intuitive, that as we aggregated more and more parameters, our specificity became very good, but at the cost of sensitivity. And the median time of this prediction was about 8 hours or so. So finally we said, okay, if we have an aggregate of 8, we would get medium sensitivity and specificity. Also depends on how we were bringing in the data. And finally, the conclusion of this was that this is a result that in the current open data sets that we have, we don't have all the information that we could possibly get. We're still limited to very basic vitals that we're looking at. We don't have digital biomarkers for renal function. We don't have any sort of activity assessment that we're looking at. Variability parameters, if in the lack of an ECG waveform or in the lack of a respiratory waveform, are also not available in current open data sets. And finally, we don't know the breathing difficulty of a patient while we're doing this. While this is not good, it was good news for us because we have a solution for this. And this is where our wearable comes and bridges the gap. that exists currently with all the monitoring systems that we have right now. Finally, I'd also like to just talk about, with this wearable, you know that they can't be too bulky because you want to put it on a child, they can't be too big. So we wanted to know, was it even feasible to do like an AI embedded in the wearables to give this feedback of whether or not this patient is at sepsis. So we ran the algorithms on our microcontrollers. We saw that actually we could get weeks of operational longevity. So you wouldn't have to keep charging the wearable every now and then, which would break then the whole course of diagnosis even. So it is possible that we have a standalone self-sufficient system that is non-invasive that can be put on any patient in any setting and run for whatever extended period of time that you have. So for example, if you have immunosuppressed cancer patients, you could put it on them for the duration of the 2 or 3 weeks that they're doing chemo and then see how that treatment is going for them. Are they going into some kind of organ failure? Are they at the risk of developing sepsis or not? And I'd close the talk with this last slide. So this is what I'd want you to remember, is that what we're trying to do here is that we're trying to take wearables and we're trying to extract novel digital biomarkers such that we can fuse them together, we can put them on an edge device, and we can actually give a clinical decision on whether or not a patient in the future is going to develop an organ failure or not. And finally, what this would look like is something like this, where you'd have the child even in an incubator or in any setting for that matter, and you'd get a percentage of, so 78% of multi-organ failure. And of this, you'd see, okay, the heart is not at risk, but actually the kidneys are failing because it's 78% here. Because the model is so variegated in the multiple tasks that it looks at, that it actually knows which system is actually shutting down. And this then we hope can also give information to the clinician about whether it's sepsis that it's leading to, whether it's cardiac failure, respiratory failure, circulatory failure, or kidney shutdown. And this we hope in the future can also help clinicians to alter their therapy routines and know how best to take care of their patients. So with that, I leave you, and thank you very much. We're happy to answer any questions.